Now I call upon Dr. Elizabeth Joseph. I don't think there is need to introduce Dr. Elizabeth Joseph, the Chief of Strabismology and Pediatric Ophthalmology Department in Little Flower Eye Hospital. Over to Dr. Elizabeth Joseph for how to go about vertical strabismus.
Good afternoon, everyone. I hope this is a crowd of Strabismus interest group. Welcome, everyone. I'll be discussing how to decode a vertical strabismus. See, all of you know that vertical deviations can be primary, secondary, or the composite type due to third nerve palsy, Duven's retraction, monoelevation defect, etc. And if you want to decode, first take a proper history. Make out whether it is congenital or acquired. Diplopia denotes an acquired problem. Look for any trauma, prior surgeries. Always ask for developmental milestones and family history. And after that, it is the examination. First and foremost, when the child comes to your OPD, look at the head posture. The head posture has got three components: head tilt, face turn, and chin elevation or depression. See, everyone should know the rules of compensatory head posture. If we by heart these rules, it's very easy for us to crack a vertical squint. See, I'll say the rules of compensatory head posture. The head tilt is towards the side of hypertropic eye. Chin is depressed in depressor palsy, elevated in elevator palsy. Face turn is towards the opposite side in oblique. If you by heart it, then you can decode any vertical squint. For example, look at these two people. Both of them have got left fourth nerve palsy. Their head is tilted towards the right side, that is towards the side of hypertropia. Face turn is to the right, that is to the opposite side, and chin is depressed to the hypertropic. Chin is depressed because it is a depressor palsy. And then we have to assess the deviation in the natural abnormal head posture position and also in the head erect position. And then assess whether the deviation is comitant or not, whether the deviation is dissociated or not. See, this is a non-dissociated deviation, right hypertropia. When you cover the right eye, the eye which was deviated upwards comes down to take a fixation. When you cover the left eye goes upwards to take a fixation. So this is a right hypertropia, non-dissociated deviation. Whereas in dissociated deviation, eye under cover always goes upwards, dissociated vertical. There is, of course, dissociated horizontal deviation, that is different. See, I'll show you the video of dissociated vertical deviation. See, primary position, there is no deviation, both eyes are straight. But when you cover one eye, the eye under cover goes up and gradually comes down. That means it is a vertical deviation. But the left eye is not going up. When you cover the left eye, the same thing happens in the other eye. So that is a dissociated deviation. Of course, dissociated deviation may be comitant or incomitant. Incomitant is due to oblique overaction. And the most important test in measurement of DVD is the prism undercover test. Management of DVD, most of the time we don't do anything, just to observe. And if it is cosmetically problematic, we do surgery. If associated with oblique overaction, tackle the oblique. If not associated with oblique overaction, do a large recession of superior rectus up to 7 to 10 millimeter with or without FA dense suture. One word about the three-step test that also all of us are familiar. You have the three steps in that. First, you analyze the vertical deviation in the primary position, then analyze the vertical deviation in dextroversion, levoversion, and then right and left head tilt. And this test is most useful for single cyclovertical muscle palsy, which is not decompensated, especially for superior oblique palsy. In superior oblique palsy, if you can remember this Woog and Boot, again that is very easy. See, the hyperdeviation is worse in the adducted position, that is in the opposite gaze, that is it's the Woog. and the head tilt is better in the opposite side, or it is worse on the same side head tilt. And after that, you have to assess the deviation in the various horizontal movements. See, this child has got a primary position exo. On adduction, the eye goes up. So this is a inferior oblique overaction producing a V pattern exotropia, bilateral inferior oblique. Of course, you have to grade the ocular rotations, and in order to test the torsion, we have the double Maddox rod test. Look at the torsion. Here you can see the torsion, and objective measurement of torsion is by looking at the fundus, by looking at the relationship of the fovea with the disc. And then I'll come to some special clinical entities. This is a child with superior oblique palsy. You can see a abnormal head posture. When the head posture is made straight, the eye is deviated upwards. You can see that the deviated upwards, and there is a defective depression. So this is a superior oblique palsy, and there are several treatment modalities for superior oblique palsy. Knapp has described extensively, and that is a very complicated thing, but it is very easy if you remember that if the deviation is less than 15 prism diopters, do an ipsilateral inferior oblique recession if the inferior oblique is overacting. If the deviation is more than 15 prism diopters, combine the inferior oblique surgery with one more surgery, either superior oblique tuck if the superior oblique is lax, or a recession of the contralateral inferior rectus if there is a downgaze diplopia, or an ipsilateral superior rectus recession if there is a superior rectus contracture. Opposite superior oblique weakening is not desirable. Harada-Ito procedure to correct excyclotorsion. See this child who underwent right inferior oblique recession with a superior oblique tuck, giving a very good postoperative appearance. See again another child, another person with superior oblique palsy with primary position hypertropia and downward diplopia, corrected by superior rectus recession of right eye and inferior rectus recession of the opposite side. So we have to titrate and decide the management of superior oblique palsy on an individual basis. Coming to secondary vertical squint, see this child has got an exotropia with an inferior oblique overaction. See inferior oblique overaction and exotropia corrected by bilateral lateral rectus recession with inferior oblique recession. And this inferior oblique recession has to be titrated. Again, see this is a case of complicated vertical squint. You can see that the see this is a Duane's retraction syndrome with upshoot on adduction and a primary position hypertropia. If there is no primary position hypertropia but just an upshoot on adduction, it can be tackled by a Y splitting. But if there is a primary position hypertropia also, simple Y splitting will not help to correct the deviation. We have to do an inferior oblique recession also. Look at the picture. See, this is a post-operative picture. You can see that the vertical deviation is corrected. Primary position also is better. Lid fissure changes are also better. The surgical procedure was Y splitting with inferior oblique recession and anteriorization. With this, I am stopping my talk. Thank you very much for a patient listening. Thank you very much.
Thank you, Dr. Elizabeth, for making a vertical strabismus, which is very complicated, how to go about it in a simple way. Thank you. Now I call